Endotracheal Intubation, Week 3, Lecture 1. So endotracheal intubation is a process of placing a tube into the trachea, commonly held paramedic skill. However, it is one of the skills that is in question on whether or not it should be allowed to be done by paramedics. The question arises is whether it should be done by even physicians at some levels. The reason for this is there are many complications with intubation and a lack of technique and practice that exists amongst medical providers. Some of the thoughts on this arise from the fact that we, number one, don't get enough tubes, especially if you work in a rural service. You can go months between intubations. And truly, to be proficient in intubation, it takes over 1,000 endotracheal tubes. For most medics, that means you will not get that in your entire career. But again, there are advantages and there are disadvantages to endotracheal intubation, and that's what we're going to talk about a little bit this evening. When you have a critically ill patient, there are numerous advantages to endotracheal intubation. It allows you to ensure and maintain a patent airway, which a patent airway would be defined as what?
Well, you're able to ventilate the patient, maintain 90% or higher oxygenation.
Yeah, you're able to actually ventilate the patient. There's actually able way for air to move in and out. You're able to control ventilation more effectively. However, one could argue that even with a BVM, you're able to control ventilation, which is absolutely true with proper technique. The other advantage of endotracheal intubation is the ability to administer medications and give patients medications down the ET tube, which can, number one, get the drug into the system almost as quickly as IV access, and number two, it allows you to introduce medications directly into the lungs that may help lungs. The endotracheal tube is non-collapsible. As long as the endotracheal tube remains properly positioned, unobstructed, and the cuffs inflated, the patency of the upper airway is virtually assured. You have a direct connection from the outside into the lungs. However, it does not protect against lower airway obstruction. Most common obstruction of the tube or the lower airway is mucus secretions. So if you have patients that have heavy secretions, you have asthma patients, so forth, just because you get the patient intubated with an endotracheal tube does not necessarily mean that all is well and you're going to be able to effectively ventilate.
Well, that's the nice thing about the ET tube, though. You're able to suction.
That's right. Once we have the tube in, we do have the ability to suction out the airway, which does make things much better and more beneficial. So, again, that serves another advantage for us. Most mucus plugs in the endotracheal tube can be easily removed by suctioning, as you brought up. Another threat to the patency of the tube is the pulmonary fluid. And positive pressure ventilation tends to decrease the volume of pulmonary fluid and bring it back into the pulmonary circulation. Especially we're talking about using PEEP valves and so forth. We're actually able to push that fluid back off and into the capillary membrane to be circulated and get it out of the alveoli to allow for better and more better gas. So to control ventilations, it's another advantage to endotracheal intubation is the ability that we have to truly control the ventilations. We're able to control with positive pressure ventilation the volume, the composition of the air reaching the lungs, the volume of the air reaching the lungs, and the pressure. We're also allowed to hold in and allow for adequate gas exchange to take place by holding in the air for a short-sighted longer period of time on inspiration. Again, we're able to control the gas mixture of the gas going in, almost getting and achieving a 100% oxygen concentration as we deliver this to the patient. Because again, we have the reservoir bag on the bag valve mask. We're in a closed system basically because we're connected directly to the tube, to the oxygen source of the BVM. As we know that the alveolar capillary membrane exists, and this all allows us to have the opportunity to administer many medications by way of inhalation. Inhalation is a major route of administering anesthetic gases for anesthesiologists, but there are other drugs that we administer as paramedics through the lungs. What are some examples of this?
For respiratory?
Yeah.
Well, we could give albuterol, Atrovent,
albuterol, Atrovent,
Zopanex.
Zopanex.
Even mag sulfate.
Yes, mag sulfate. Again, or your racemic epinephrine. You can go that way. Many of our co-drugs can be delivered down the endotracheal tube. Our epinephrine can be delivered down that way. Basically, you can follow the old adage of Nebul, which is naloxone, atropine, vasopressin, epinephrine, and lidocaine. So the administration of medications by the endotracheal tubes has significant advantages. Bronchodilators are delivered directly to the site of action and work more quickly. And the medication is allowed to actually get there and diffuse across the pulmonary circulation, allowing it to work much quicker and more efficiently. So the key to successful administration of medications by the endotracheal route is the medication must reach the alveolar capillary interface. So it's got to be nebulized or atomized. All too often times when medications are given endotracheally, people forget that you actually need to atomize the medication. And if you remember what atomization is, if you just think back to being a basic and learning about a mucosal atomizer device for giving Narcan, as you push that medication through, it actually turns it into a fine mist. And that allows it to have that greater surface spread out to come in contact with those lung tissues. Simply dumping the medication down the tube is not necessarily going to be as efficient as that. So nebulization occurs when the velocity of gases pass through the liquid, and this causes the gas to form the mist. If medication is injected through this mount, it's going to be delivered into the lungs more effectively and more efficiently, because again, those gases are going to expand that liquid medication into a fine mist. Not all medications can be given down the endotracheal tube. Like I said earlier, pretty much you can follow the old adage of Nebul, but currently the American Heart Association only recommends that lidocaine, epinephrine, atropine, and naloxone be given down the ET tube. That's not to say that's excluding the drugs that you normally would give through the lungs, which would be your albuterol and atropine, as I had a brain fart there for a moment. I apologize. To get them to the tube.
What about our opiate analgesics? They frown upon us giving that down the ET tube?
Yes, those are not approved to be given down an ET tube.
Because of the potency of the drugs and how we're supposed to give it 2 to 2.5 times the amount?
That's one reason why, and the fact that too is many of those drugs will also have an oil-based viscosity to them, which make it difficult, which basically means they're not going to be picked up in the lung, and actually going to cause more harm to us than good. The key to remember too when we're giving drugs is, like you just brought up, is you've got to give 2.5 times the volume. So if you're given 1 milligram of epinephrine, you're technically going to have to give 2.5 milligrams of epinephrine if you're going to go down the endotracheal tube. If you're given 2 milligrams of Narcan, you're going to have to increase that volume as well. So most of the time we'll dilute the dose down into 10 mLs of saline and place it down the tube and allow it to have the nebulization take place. Now there are commercially available endotracheal nebulization kits that will help nebulize that medication, or again, many times you can just squirt it down as you're bagging. The bagging motion itself will assist in nebulizing medication. So why are we going to endotracheally intubate someone? What would make us think that we needed to do that?
You know, I'm not sure.
Yeah, you needed to definitively control the patient's airway. There's no other way to definitively control the airway other than endotracheal intubation. Endotracheal intubation is the only definitive airway. Combi tube is not a definitive airway. A LMA is not a definitive airway. Endotracheal intubation is a definitive airway because it is directly placed in the trachea. We know that we have isolated off the lungs from everywhere else, so it's a definitive source. To take control of the patient's ventilations will be another reason why. Patient's not ventilating well enough, we need to do something about it. Or again, to administer those endotracheal medications. Those are going to be our three primary reasons for intubating a patient. So any patients that's at a significant risk for losing the patency of their airway, or if they have a decrease in the level of consciousness, or a suppressed gag reflex, and or both, these patients are at risk for what? If they have a decreased level of consciousness and they don't have a gag reflex.
Probably not breathing adequately.
They're not breathing adequately, and they've got a risk for aspiration. So we need to secure their airway. Remember, there is a huge difference between controlling the airway and getting ventilations. You can ventilate without an ET tube. However, you cannot secure the airway without an ET tube or without some other type of device. So that's going to be one of the main reasons that we do this. Trauma patients are particularly at risk for losing their airway due to airway obstruction and aspiration. So as a general rule, what we follow is anybody that's got an altered level of consciousness is decreased enough to cause their gag reflex to be diminished, we need to intubate them to ensure a patent airway. The old adage that's been around for a long time is under 8 intubate, and that's what we're talking about with a GCS. If you have any patient that's got a GCS score of less than 8, you probably should consider intubating them. But there are going to be patients that are going to have GCS scores higher than 8 that you're probably going to have to consider intubating as well. Now, we don't have RSI as a protocol available to us. However, this is why rapid sequence induction exists, is for this reason of for those patients that are not completely out yet, but they do have that altered level of consciousness, and you see that potential need for intubation, we have that ability to do so.
Let's fast forward. Let's say we've already intubated the patient, but somehow, by some act of God, they have began to come out of it. Could we give succinylcholine and such down the tube, or not?
Not down the tube. However, if you've got a patient that's a good question. You have a patient you've intubated. Your patient's starting to come around. Now, we'll talk about this in post-intubation management next week. But absolutely, we may need to consider giving them a drug, because you don't necessarily want to lose that tube and necessarily extubate them when the expected course is going to be they're going to go right back to where they were to begin with. So you may not paralyze them, but you may keep them sedated with a little Versed, some painkillers possibly, just to keep them down enough. However, one thing to keep in mind, and we'll talk about this in RSI, you are not cleared in New Mexico to chemically facilitate intubation. So don't get misconstrued. If you need to keep a patient down, that's one thing. But don't take a patient down in order to intubate them, unless, of course, you have the special skill for RSI. So another reason why we intubate is, again, to control ventilation. Patients who require respiratory support need to be intubated. Chronic or acute lung diseases, congestive heart failure, asthma, cardiogenic and non-cardiogenic pulmonary edema. These are all prime indications for intubation. However, I will tell you that due to recent technological advances, i.e. CPAP in the field, the need to intubate these patients has drastically gone down. Because, again, CPAP allows us to control those ventilations. It allows us to isolate out because we do have an airtight seal on that mask. And these patients are actually able to improve without the facilitated intubation. So, again, not always going to be an indication here to intubate these patients because we do have other alternative means available. Patients that are in respiratory failure. Remember, a patient will progress from respiratory distress to respiratory failure to respiratory arrest. Hopefully we can head them off before they get to respiratory arrest. But patients that have respiratory failure can be identified by the fact that they're having severe difficulty breathing and unable to speak more than a few words at a time. These patients are doing everything they can to maintain their airway and maintain their respiratory rate. However, there's going to come a time when they're going to not be able to do this anymore, and we're going to need to offer them ventilatory support. So patients that have pale, dusky, cyanotic skin and begin to experience a decreased level of consciousness, you definitely need to consider the fact that these patients probably need to be intubated. You definitely should have that in the back of your mind and start to prepare your equipment to facilitate such intubation. Do you have a question?
Yes. Let's say you have a patient that has a tracheotomy and they've had some sort of facial trauma causing damage to the throat, damage the stoma. They've damaged the stoma. How are we going to intubate that?
Well, you try to replace the tube down their stoma.
Okay.
Yeah. And you're not going to necessarily intubate that. In that case, the stoma, again, that's going to be lowered in your cricothyrotomy, so you're probably just going to use your tube there to get it in at that point.
Yeah, I understand. I'm talking about if there's damage to the throat where the stoma's been blocked or crushed.
You're going to do anything in your power to try to control their airway as best you can. I don't have a definitive answer to tell you, because if they truly have a disruption in their stoma and there's more trauma in that area, I don't really know how you're going to manage your airway without some blood, sweat, and tears. It's basically what it's going to go down to. And hope for the best. Hopefully the EMS gods will be on your side on that one, because that's actually a good question. It really is. So anytime a patient's pulse ox is less than 96%, you should look at the cause or a plausible explanation. An SpO2 of less than 90% is definitely a cause for concern. Patients who have high CO2 levels, if their PaCO2 or their capnography is greater than 50 millimeters of mercury, these patients almost always need to be intubated, or you need to be considering intubation in these patients. Because again, what kind of patients are going to have high levels of CO2 typically?
Patients with any type of intracranial pressure or increase?
Okay, intracranial pressure is going to be one cause of increased CO2.
Any trauma patient, really.
Trauma patients, your lungers, your COPD patients, your asthma patients, all of these guys are potentially going to have the need to be intubated and their ventilation controlled. Table here just shows you some different signs of respiratory failure. Anxiety. Remember, as the brain gets starved of oxygen, one of the first things that it gets is anxiety. Then we start to become hostile. Then we progress down to starting to have an altered level of consciousness. Sympathetic overactivity, dyspnea, speaking 1 to 2 word sentences, or the total loss of ability to speak, accessory muscles, self-peeping or self-positive end expiratory pressures, patients breathing against pursed lips, pursing their lips to help keep that airway open. These patients learn to do that have COPD. It's like having CPAP built into themselves. If you breathe through pursed lips, it keeps your end expiratory pressure higher. Cyanosis, decreasing pulse ox, decreasing PaO2, CO2 rising, and uncompensated respiratory acidosis are all going to be indications for or signs of respiratory failure. Just like any medical procedure we do, there are complications of endotracheal intubation. Lots of life-saving potential for it. However, there are going to be complications, and you can potentially kill your patient if you intubate them, especially if you get their gut the tube, which is a very, very commonly occurring thing, and you don't recognize that. You're basically not going to be doing your patient any good, because all of the air is going to be going to the gut. So one of the complications of intubation is hypoxia. hypoxia is a result from the period of time during the intubation when the patient goes without oxygen. That's why we always try to do our best to pre-oxygenate patients before we intubate them. Ideally, we should have their pulse ox above 96% during intubation, but really what we're going to talk about is having a high hyperoxygenating a patient prior to intubation, or having your partner do that while you prepare. If you can effectively hyperoxygenate that patient with 100% oxygen by BVM, having your 2 adjuncts in place, having everything going correctly, by doing that 100% oxygen, you cause nitrogen washout to occur. By doing that nitrogen washout, you get rid of all the excess crappy gas that we don't need. You get it out of their system, and then you open it up with that high oxygen level. So now we have totally, completely hyperoxygenated our patient. We've got a pulse ox reading of 100%. If we were to draw an ABG, we would see that the patient probably has a PaO2 of 120 to 140, which buys us time in a healthy patient. You can actually spend 10 minutes without oxygen on these patients and not see their pulse oximetry level drop off. Because again, we've completely saturated the whole system. We have high concentrations of oxygen in the plasma and high concentrations of oxygen, of course, the hemoglobin being fully loaded. So if you have a patient whose oxygen saturation is dropping despite the supplemental oxygen, you definitely want to do your best to get these patients intubated as quickly as possible. Patients who are in cardiac arrest and those in shock do not allow for reliable pulse oximetry readings. Why is that? Why is somebody in cardiac arrest not going to have a valid pulse oximetry reading?
Before or after we intubate?
Before or after, either one, if they're in cardiac arrest.
Well, before, I mean, self-explanatory. They're probably not even breathing.
Okay.
Afterwards, it's probably the technician's fault. They're probably not adequately ventilating the patient, or the ET tube could be out of place. You could be in the stomach.
Okay, could be in the stomach. Yeah, the other thing too to remember too in these patients is that in cardiac arrest is the blood stagnant. It's not moving anywhere, so you're not actually seeing that oxygen get loaded up. The other thing that goes along with that is these patients in shock, if they're losing blood, even if their oxygen saturation says they're 100%, remember, if they're normally running with 500 buses and now they're down to 300 buses, there's a problem there. Yeah, they're 100% full, but they've got about a 200 bus deficit, and the bus being hemoglobin. So that's definitely going to give us a false sense of security. A rule of thumb to always follow is an intubation attempt should take no longer than 30 seconds. And that's important to kind of remember. However, get the job done. With good pre-oxygenation, you've got yourself some time. The biggest key to this is relaxation. They used to teach people, hold your breath. Well, yeah, you can hold your breath for a long time. Or the other thing that goes along with holding your breath is you've got so much adrenaline, what you think is 30 seconds is actually only 10 or 15 seconds, and you're already ready to take another breath. So holding your breath is not really a good indicator. Kind of goes back to the whole concept of crew resource management, which means have your partner help you with that. While you're intubating, have your partner sit there and watch the clock and let you know, hey, buddy, you've been in there too long. That's always going to be a good indicator. And, of course, watch your pulse oximeter, watch your cardiac monitor, all these other things that go in line with that. Dysrhythmias are another common complication of intubation. Physical stimulation of the upper airway by the tube. The instrument of intubation can stimulate that vagus nerve. You can get dysrhythmias like PVCs and so forth, as well as if you cause pressure on that vagus nerve, many times what you're going to actually see happen is you're going to see that patient start to brady down. So you'll get a vagal response as you blade that patient and start to pass that tube down the trachea. Tracheal trauma. You get tissue swelling, sitting around there stabbing around. You start to cause some trauma in that airway. Realize that no matter how careful you are with intubation, there is going to be some trauma that's going to be caused on that trachea. The other thing that goes along with even not even passing the tube is the fact that you're going to be inflating that pilot balloon. And as you inflate that balloon or your cup on your endotracheal tube, it's going to cause pressure on that tube as well, or on that trachea as well, which is going to cause some trauma. Overinflating the cuff is designed to hold 10 cc's or 10 milliliters of air, not 20, 30 cc's of air. It will hold that many times without even busting. But again, as you put more and more pressure on that, you're going to basically put pressure on that trachea, and you're going to cause pressure sores to develop. You definitely don't want mucosal necrosis to happen in that trachea. So again, you want to try to do your best to prevent that from occurring. As you pass that tube through the glottic opening, you can very easily damage the vocal cords. Let's hope that you're not intubating somebody like Britney Spears or Blake Shelton or somebody in those lines who depend on their voice to make a living. Because if you do, they're probably not going to be singing. They're going to have Julie Andrews syndrome from The Sound of Music. If you know what The Sound of Music lady was, she's not going to be able to sing anymore. So don't overinflate your cuff either, because overinflating your cuff, if you do have any closeness to that glottic opening, you can damage those vocal cords. Okay. I don't think your vocal cords are damaged, though. I think your vocal cords are going to be just fine. All right? Yeah. So another thing that we get is laryngospasms. Especially now when you're intubating a dead person or somebody that's in cardiac arrest, you're not typically going to have these laryngospasms. But intubating somebody that's alive, you will get these laryngospasms. And what happens is you touch those vocal cords with your endotracheal tube. As you go to intubate, you will start having the spasms occur in the larynx and vocal cords, and you'll see them sitting there closing and slamming shut.
The mammalian diving reflex.
Yes, it goes back to the same principle as a mammalian diving reflex. It's going to do everything it can to prevent anything from entering into that trachea. So the point of this is, when you intubate someone, make sure that you attempt to pass your tube when the glottis is opening, or when those cords are open, and get it in one fluid motion. Don't sit there and tap and play on the vocal cords, because as they slam shut, many times you're not going to open back up for quite a while. So again, get your tube through and get it in quickly. Remember that persistent laryngeal spasms can be life-threatening, because as long as those, the larynx is closed, is air able to get into the lungs? No. So we've got that problem. Oftentimes an aggressive jaw thrust, causative by positive pressure ventilation, can assist with the laryngeal spasms. Because we are in a closed system, barotrauma becomes a concern for us as well. We have a cupped endotracheal tube which seals off the air escape, so air has but one way to go, down. And as long as you're squeezing that bag, air is going down and it can't escape and come back up. So once we get that endotracheal tube in, we really have to be conscientious about our volumes, because if we overinflate, we can definitely cause a pneumothorax, a pneumomediastinum, subcutaneous emphysema, or even a tension pneumothorax to occur, because we've hyper inflated those lungs and actually caused air escape and leakage in that barotrauma.
If we do that, are we just going to see a decrease in O2 saturation?
You see that, you're going to see lung sounds that are going to be affected. And if you've got a pneumomediastinum, you're very often going to see signs and symptoms of Beck's triad or a pericardial tamponade, because that air is going to be in that mediastinum case. So you're going to see the blood pressure, you're going to have the narrowing pulse pressure, your numbers are going to start coming closer together, your heart tones may be a little bit muffled, you may start to get some JVD. With the others, if you've got a pneumothorax, you're going to have the same signs, diminished or absent lung sounds. If you've got a tension pneumothorax, you're going to start to see that displacement taking place. Bronchial intubation, so occasionally that does occur, and like I alluded to with anatomy and physiology lecture, when you go to intubate these patients, very oftentimes what we see is because the right mainstem bronchus is a straight shot down from the trachea, and the left tends to curve off a little bit, if we go in too deeply with our endotracheal tube, a lot of times we will actually get that tube placed into the right mainstem. It'll be a right mainstem tube. So it'll rest in that right mainstem bronchus. That's an easy fix when that occurs. But what we really want the tube to be placed is halfway between the vocal cords and the carina. And we know the carina is that branch off that we have, and the carina is right at our sternal notch there. We want it to be halfway between those two spots, which places it just inferior to that sternal notch. Main stem intubation can be avoided by a number of techniques. Number one is you want to insert the tube under direct visualization. You want to see what you're doing. You want to reassess bilateral breath sounds. And one thing I cannot stress enough is before you intubate anyone, you should listen to lung sounds. You should be listening to lung sounds and getting your baseline. Because what happens if your patient had a lobectomy and is missing their left lung, and you're listening after you intubate, and you hear air sounds on the right, but you don't hear any lung sounds on the left. And you don't know they had a lobectomy, so you're going to really start freaking out. You're going to think you right mainstem the tube, you're going to back out, and you keep backing out, and you still only have right-sided lung sounds.
You always have to have a constant variable.
You always have to have that constant variable, so you should always listen to pre-lung sounds, post-lung sounds anytime you move the patient. And here's the key. You are the one that needs to listen to the lung sounds, not your partner, not anybody else. I don't care how well you trust your partner. Your partner can be your wife, and you've been married forever, and you can been working together for 20 years. You still need to be the one that listens to those lung sounds, because ultimately, who is the one that's responsible for that patient?
You.
You are. That's correct. So distance from the teeth. The vocal cords are about 15 centimeters. The sternal notch is about 20, and the carina is about 25 centimeters. The proper depth of insertion on the tube is going to be 21 to 23 centimeters at the teeth. Okay, and you always need to make note of that and pay attention when you intubate someone. So again, you're going to make note. I've got the patient intubated with a 7.0 ET tube, and it's at 22 at the teeth. So another complication that we get into when we have intubation is esophageal intubation. Even an endotracheal tube that is properly positioned in the trachea can become displaced by either the patient's head moving around or inadvertent manipulation of the tube. One thing that you should always do anytime you intubate someone, and it needs to become practice for you to do this, and we will always do it in the lab, is put a C-collar on them. Because after you get them intubated, because moving their head around could potentially displace your tube. If you put that C-collar on, it's going to make sure that that tube stays in place and doesn't move around. So again, anytime you intubate someone, you want to do that, because you don't want to have that esophageal intubation take place. So esophageal intubation results from the tube being placed into the esophagus. And it will cause the patient's stomach to swell and become overinflated with air. You need to constantly monitor this. What's going to tell you, or what's going to be the key that's going to let you know that you've got an esophageal intubation?
Distension of the stomach.
Distension of the stomach, and before you even see distension, what are you going to hear?
Gurgling.
Gurgling in the stomach when you ventilate. So that always needs to be the first place you listen when you intubate someone, is listening to those epigastric sounds to see if you've got air in that location. Now, just like advantages, there are disadvantages of endotracheal intubation.
Before we move on, what if your patient had developed a ruptured diaphragm?
Is this pre or post intubation?
This is going to be post intubation.
No problem. It's no problem at all, because you are now, because so you're asking like a diaphragmatic hernia?
Yes.
Okay, so if you've got a patient that's got a diaphragmatic hernia, either pre or post, what the problem is they can't negatively ventilate, negative pressure ventilation, because that's going to interfere with that, because that diaphragm, as it creates that vacuum, it's not going to create a proper vacuum. So we've got them on positive pressure ventilation. So this is going to be your key to treatment of a hiatal hernia or a diaphragmatic hernia, is to actually have them intubated and ventilate them that way, because this way you're ensuring that those lungs are actually able to inflate.
Well, won't you hear epigastric sounds with that though?
Are you like saying? So you may hear stomach sounds up in the chest. I see what you're saying. You may hear stomach sounds up in the chest, but again, as long as you've got your other confirmation methods going on, and there are many confirmation methods. One confirmation method is, again, listening to make sure you've got lung sounds and no epigastric sounds. But what's your end-tidal CO2 reading? What is your do you have misting in the tube? Those are some other methods for you there. Those are all things that you're going to want to look at when you have this patient intubated to ensure that you're there. That kind of makes sense?
Yes.
Okay. So for air to be used in the lungs, the air has to be warmed, humidified, and so forth. Well, now we've lost the ability to warm and humidify this air because it's not going through the nose, it's not going through the mouth, it's going straight from the environment down into the lungs. So cold, dry, unfiltered air can cause tissue damage. It's important to remember that. So we want to do our best to keep this air humidified and warm it up as best we can to make sure that it's more efficient. So just to recap, reasons why we want to intubate patients: they have a decreased level of consciousness, they have a risk of regurgitation, they have a depressed or absent gag reflex, respiratory failure, respiratory arrest or cardiac arrest. The contraindications, there are none in the emergency situation. Advantages: it ensures a patent airway, it reduces the risk of regurgitation, it causes improved ventilation, and it's a route of administration for oxygen and other drugs. Disadvantages, again, it bypasses the function of the upper respiratory system, complications, hypoxia during insertion, dysrhythmias, tracheal trauma, laryngospasms, and potentially barotrauma. It's important to remember that sometimes we're going to have to anticipate a difficult intubation. Most of the time when you need to intubate the patient, you really don't have time to do a real good assessment on these in an emergency situation, especially if it's a non-elected intubation. We just kind of grab our stuff and go for it. But if you anticipate difficult situations, you're going to make things much better for you in the long run. It's invaluable to be able to, or very valuable rather, to be able to identify patients that are going to have a difficult intubation and be prepared for those to minimize the complications. So for those of you that would have to intubate me, am I going to be an easy intubation or a difficult intubation?
Very difficult.
Why?
Well, I'm not sure. I just remember hearing that.
Well, I'm going to be a difficult intubation because I have a big neck. Anybody that's got a big neck is going to have is going to be a difficult intubation. My plane and axis are going to be harder to line up, and I'm going to have a very, very crappy Mallampati score. So those are all going to be things that are going to make me difficult to intubate. So so we want to try to assess those. Size is not the only indicator for who's going to be an easy intubation or a difficult intubation. Think about somebody that's got an overbite. Patients that have overbites are going to be difficult intubations. You can have patients that are going to be anterior in terms of their airway. Patients that have structural deficits. Somebody that's got a forked tongue. Granted, that was done cosmetically, but that's going to be difficult. Somebody that's got tongue swelling. Somebody that's got a ball or a piercing in their tongue. There's all kinds of different things that are going to make for an intubation to be more difficult. But we want to anticipate those so we don't run into a brick wall. So keeping in mind a patient's pre-existing condition, like somebody that's got rheumatoid arthritis, and the rheumatoid arthritis is attacking their cervical vertebrae. Are you going to be able to manipulate their neck like you need to? Anatomical features. and may just make it very, very difficult for us to be able to manage them. So we want to definitely get a good history on these patients. Certain medical conditions will help you with your decision on intubation. Congenital abnormalities may cause anatomic changes that affect your success at intubation. Histories of recent surgeries, head, neck trauma, tumors, infections can increase the difficulty. So again, these are all things that we want to find out about and try to gather. So we kind of use the mnemonic LEMON for pre-intubation assessment. We want to look at the patient. We want to evaluate the 3-3-2 rule. Look at the Mallampati Class and check for obstruction, and look at neck mobility. So looking at the patients, one of the most important clues on this is going to be looking at the patient's general appearance. Patients that are tall, thin, are typically easier to intubate than those that are short and stocky. Patients who have short, muscular, thick necks can be extremely difficult to intubate. Obesity it also causes problems with intubation due to the fact that there will oftentimes be extra tissue in the oropharynx. Look at the mobility of the patient's mandible and head prior to evaluation of or the decision to intubate. Patients that have large teeth, overbites, all of these are going to get in the way of our laryngoscopic view of the glottic opening, making things difficult. Patients that have dental trauma, that's a complication. The missing teeth, as you see in this picture here, create a trap for the laryngoscopic blade. As you go to put the blade in, you're very oftentimes going to get that caught in there. Cause problems. Then we want to look at the 3-3-2 rule. So the first three refers to mouth opening. The mouth should open wide enough for 3 fingers to be inserted between the patient's upper and lower teeth. And these are the patient's fingers. Patients should be able to open their mouth and put 3 fingers in between their teeth. Everybody should try that. See if you can get your 3 fingers in between your teeth. In your book. All right. But basically, anybody that's got a grade 1 should be very, very easy to intubate. A grade 4 is very difficult to intubate. So if you open your mouth right now, I should be able to see the back of your throat. All right. If I can see all of that and I can see some openings back there, we're good to go. If I have you open your mouth now and all I see basically is your tongue and your soft palate, that means we're going to have some issues with intubation. Okay, that would be a class 4. Okay. So tongue has a large to-do with the Mallampati classification. Patients that have a Mallampati class 3 airway, only the soft palate's going to be visible. So type 1, they're going to have it all visible. Type 2, you're going to have part of the uvula out of view. And type 3, all you're going to see is the soft palate. Okay. So here we can see grade 1, class 1. So grade 1, the entire glottis is fully exposed. Grade 2, the glottis is partially exposed. All the way to a grade 4, neither the glottis or the corniculate cartilage can be visualized. So, and in the classifications, this is just talking about your success at intubation, or how easily facilitated intubation is going to be. So grade 1 you can see is an 80% to a grade 4 all the way to a 10% chance of intubation. So again, we want our patients to somewhere lying here in the 80% mark, not over here in the 10% mark. Obstructions. Patients can have obstructions that interfere with the view of what you're looking at. They can be caused by pathological structures such as tumors that are in their airway, swelling that's there from either their tonsils being swollen or whatnot. Liquid is a huge obstruction for us, and semi-liquids.
What about esophageal varices from chronic drinking?
What about it? Will that cause obstruction?
Yeah, because if we rupture it,
Yeah, there's going to be blood, and you're going to have to deal with the blood, which is just as bad as dealing with blood, vomit or frothy sputum. So the key to that is having your suction available and constantly suctioning. And if you've got enough hands present with you, many times while you're blading these people to intubate them, you're going to need to have continuous suction going on in the mouth in order to be able to see what structures you're dealing with. Because ultimately, the key to intubation, and everybody needs to remember this point, if you miss everything else out of this lecture and you don't get anything else out of this lecture, the key to intubation and successful intubation is visualization of the tube passing through the glottic opening. If you cannot see that tube enter the glottic opening and go down into the trachea, then you don't know that that tube is there. Even if you listen to the lung sounds, look at end-tidal CO2, look at all of your other various sundry of confirmation devices, nothing is as good and as beneficial as actually seeing that tube pass through the glottic opening. And if you have blood, vomit, frothy sputum, other crap in that airway that's impeding your view, are you going to be able to see this?
Nope.
No. So this goes back to my other remark that was said about a week ago. Don't be lazy. Check your suction unit. Take your suction unit in with you, or have suction readily available. If you've got somebody that's got a solid foreign body, you've got tools for that. They're called McGill forceps. Get your McGills out. Get the foreign body out of there so when you intubate. If you've got continuous flow of liquid coming out of the airway, the liquid can make it very difficult to intubate. Positive pressure ventilation is going to increase the risk of aspiration. And remember, especially if it's stomach contents, patients that aspirate stomach contents have almost a 90% mortality rate. 90%. That means 9 out of 10 of those patients are going to die. So don't let them aspirate their stomach contents. So have your suction ready. The best defense is going to be using that suction unit. Immediately upon identifying any airway structures, have someone get your suction and suction it out. Because the key is once you find your landmark and find your structures, when we talk about intubation, you never take your eye off the prize. So here's the deal. You're in there. You got your blade in. You found your glottic opening. You move your head. You look over to go get something, and you go back. Guess what?
it's gone.
It's gone. And you may not find it again. So once you find it, don't take your eyes off of it. If that means your partner has to stop doing something for a second to get you what you need, let them do that. Because again, you don't want to take your eyes off the goal once you find it. Again, patients that have neck mobility issues are going to make intubation difficult. Movement of the head is critical for intubation. It is possible to intubate somebody that's got spinal mobilization in place, but again, decreased neck mobility increases the difficulty in aligning the planes, and that's what we're really truly trying to do, is align those planes. So, but again, if you've got somebody that's got a C-spine injury, they have rheumatoid arthritis or any type of fused vertebrae or anything in that neck that's going to impair their ability to move that neck around, it's going to make for a more difficult intubation. If you have to just provide manual airway management and positive pressure ventilation in these cases, that's fine. Because again, you don't want to take the chance of causing further trauma or further damage to intubation if